Okay, well, the last time we met was 2 weeks ago. And we had our exam on the muscle relaxants last week. So in the interim, just a pure coincidence, lucky for me, the New England Journal of Medicine had a video. They put out videos usually every week. And guess what their video was on? Neuromuscular monitoring. So I thought, oh, before we leave the muscle relaxant topic, why don't we watch that video? It's kind of cool. It's pretty much the same as what we did already, but it never hurts to repeat and somebody different saying it and showing it and so on. And of course, they've got millions of bucks to do theirs. So anyways, let's watch a video. And it's about 11 minutes long. So I'm going to try to play it. See if it works.
This is a video in clinical medicine from the New England Journal of Medicine.
This video focuses on the methods used in most clinical practices to assess neuromuscular function after the administration of neuromuscular blocking agents. Because these agents can be lethal, clinicians should be familiar with the use of nerve stimulators and monitors to assess neuromuscular function. It is important to understand the principles of normal neuromuscular transmission when you are using neuromuscular blocking agents. The neuromuscular junction consists of the motor nerve terminus, the postsynaptic muscle end plate, and the intervening gap.
Can you hear it okay?
An action potential reaching the motor nerve terminus triggers the release of acetylcholine from synaptic vesicles. Acetylcholine then rapidly diffuses across the gap to the postsynaptic end plate, where nicotinic acetylcholine receptors are clustered. These receptors convert the chemical signal into an electrical impulse, causing depolarization in the postsynaptic membrane. Excitation-contraction coupling immediately results in muscle contraction. The action of acetylcholine is terminated by dissociation from receptors and passive diffusion away from the end plate, and by enzymatic degradation by acetylcholinesterase. There are two types of neuromuscular blocking agents, depolarizing and non-depolarizing. These are classified according to their mechanism of action. Succinylcholine is the only depolarizing neuromuscular blocking agent that is currently in use. It mimics the action of acetylcholine at the nicotinic receptor, producing sustained depolarization of the muscle end plate, which causes fasciculations and subsequent flaccid paralysis. Spontaneous recovery typically occurs in 7 to 12 minutes. Non-depolarizing neuromuscular blocking agents, such as methylronium, bind competitively to the nicotinic acetylcholine receptor, blocking the ability of acetylcholine to produce depolarization and leading to flaccid paralysis. Neuromuscular blocking agents make a variety of life-saving procedures possible. However, these agents can be lethal unless appropriate ventilation is provided and the use of a peripheral nerve stimulator at a minimum, or a monitor whenever possible, to guide administration of blocking agents is recommended. Assessment of neuromuscular block during airway instrumentation can preclude complications such as failure to ventilate, airway trauma, regurgitation and aspiration, and optimizes intraoperative surgical conditions. Confirming the return of adequate neuromuscular function is also important prior to endotracheal extubation to ensure that the patient has adequate muscle strength and avoid hypoxemia. Thus, monitoring neuromuscular function before, during, and after the administration of neuromuscular blocking agents is vital to patient safety. Monitoring neuromuscular function involves stimulating a peripheral nerve and evaluating the contraction of the innervated muscle. Peripheral nerve stimulators are generally battery-operated, handheld units that produce various patterns of stimulation, either directly or through wires connected to electrodes on the skin. Neuromuscular monitors not only stimulate a nerve, but also measure the evoked muscle response. Nerve stimulators and the stimulation units of the neuromuscular monitors deliver currents at amplitudes ranging from 0 to 80 milliamperes. The threshold current has the amplitude necessary to evoke a muscle contraction. The maximal current has the amplitude necessary to evoke contraction of all fibers in a muscle. The supramaximal current has an amplitude 30% greater than the amplitude of the maximal current to ensure consistent contraction of all fibers despite changes in resistance over time. The silver chloride interface of the electrode reduces skin resistance and enhances delivery of the current to the nerve. To ensure that the nerve stimulator is functioning properly, check the battery, aesthetic connections to the cables, confirm electrical output, create a closed circuit and deliver the current while monitoring the amperage. The unit has a readout display. To ensure adequate electrode contact, cleanse and abrade the skin. It may be necessary to increase the current in obese or edematous patients. When possible, monitor the adductor pollicis muscle. It is the only hand muscle of the femur eminence that is innervated solely by the ulnar nerve. Monitoring this muscle helps to ensure that the muscle contraction is generated by a nerve impulse rather than by direct muscle stimulation. To monitor the adductor pollicis muscle, place stimulating electrodes on the anterior surface of the forearm along the ulnar nerve. Place the distal negative electrode 2 centimeters proximal to the wrist crease and place the positive electrode along the ulnar nerve 3 to 4 centimeters proximal to the negative electrode. If it is not possible to monitor the adductor pollicis muscle, the flexor hallucis muscle can be used. In this case, place the electrodes posterior to the medial malleolus along the posterior tibial nerve to monitor plantar flexion of the big toe. Other muscles have been used for monitoring, but these muscles may not provide accurate responses. A common but problematic practice is to place the electrodes on the face to monitor the response of the orbicularis oculi or corrugator supercilii muscles of the eye. Improper placement of electrodes on the temple and lower jaw may lead to direct muscle stimulation and erroneous assessment of neuromuscular recovery, particularly if the responses are assessed visually. Erroneous assessment can increase the risk of postoperative residual paralysis. Nerve stimulators can deliver a variety of impulse patterns that can be used to assess the intensity of neuromuscular block, including single twitch, train of 4, tetanic stimulation, post-tetanic count, and double burst stimulation. The single twitch is one supramaximal stimulus applied to a peripheral nerve while observing the evoked response. A supramaximal single twitch at a frequency of 0.1 Hz or 1 Hz can be used to determine the onset of action of a neuromuscular block. The single twitch is not helpful in determining adequacy of recovery. The train of 4 pattern consists of 4 sequential single twitch stimuli called T1, T2, T3, and T4, delivered at a frequency of 2 Hz. The train of 4 response ratio is calculated by dividing the T4 response amplitude by the T1 response amplitude. Calculate the train of 4 ratio before administering muscle relaxants and use this ratio as the control ratio. The ratio should be 1 or 100%. During a partial non-depolarizing block, the ratio decreases or fades as the block increases. There is typically no fade with a depolarizing block. The amplitude of each twitch is constant, but is diminished proportionally. There is a predictable relationship between the percentage of postsynaptic receptor occupancy and the fade of the train of 4 ratio that is caused by a non-depolarizing neuromuscular block. Up to 70% of nicotinic acetylcholine receptors can be blocked without any apparent decrease in the train of 4 ratio. As the neuromuscular block progressively increases, the train of 4 ratio progressively fades. All 4 twitches become undetectable after more than 95% of the receptors are blocked. Deliver a train of 4 sequence and assess the degree of phase objectively for tactile needs, or when T4 disappears, by counting the number of responses, which is known as the train of 4 count. The train of 4 ratio remains consistent over a range of stimulating currents. This consistency at various stimulating currents allows this pattern to be used as a measure of neuromuscular recovery, because currents of 20 to 30 milliamperes do not cause significant pain in most patients. In contrast, supramaximal currents of 60 to 70 milliamperes can be done. Double burst stimulation is delivered by administering two intense stimuli, which are mini-tetanic bursts, 0.75 seconds apart. The two fused muscle responses can be evaluated as a direct comparison, similar to the drain-on-4 ratio. Because the two individual bursts are tetanic in frequency, a recovery period that is longer than the drain-on-4 recovery period of 20 seconds between bursts is necessary. As compared with the first burst, the second burst elicits a diminished response or fade during partial non-depolarizing block. Clinicians are better able to detect residual block by visual and tactile means with the use of double burst stimulation than with the use of drain-on-4 stimulation. For more information regarding indications of each pattern of stimulation, see Figure 4 in the Prince supplement. Subjective evaluation of neuromuscular function may consist of feeling or seeing the response under stimulation. However, subjective assessments are not accurate. For instance, when the drain-on-4 ratio recovers to a value of 0.4 or higher, detection of drain-on-4 fade is not reliable. Subjective detection of fade during double burst stimulation or 100 Hz tetanic stimulation may approach the threshold of adequate recovery, but such evaluations are painful and should not be performed in conscious patients. Therefore, decisions that are based on subjective or qualitative evaluations are frequently incorrect. Clinical tests such as grip strength, leg lift, and head lift are similarly inaccurate detectors of residual fade, yet they continue to be used. These clinical tests do not require sufficient muscle function to allow for the identification of residual neuromuscular weakness. Although these tests cannot rule out residual block, they can provide useful information in settings where more accurate monitors are unavailable. Objective evaluation involves recording, processing, and measuring muscle responses to nerve stimulation. In the clinical setting, the tool used most frequently for the objective evaluation of neuromuscular function is acceleromyography. To perform acceleromyography, affix the accelerometer onto a moving digit, ideally the thumb, to measure acceleration in response to vulvar nerve stimulation. It is not difficult to set up an acceleromeography device. The thumb must be allowed to move freely, and there can be no movement of the hand or the arm, since any such movement may change the direction of thumb abduction or the baseline measurement, necessitating recalibration. Nerve stimulators are remarkably safe devices. However, complications can occur, including pain during neurostimulation, myalgias, nerve damage caused by pressure from the electrodes, and burns resulting from equipment malfunction. Nerve stimulators can also interfere with electrocardiographic monitoring and may cause an implanted pacemaker to malfunction. Monitoring neuromuscular function is recommended whenever neuromuscular blocking agents are used. Clinical or subjective assessment is unreliable. Routine nerve monitoring performed with objective measurement techniques provides additional safety with minimal risk to patients and helps to avoid potentially life-threatening complications.
Well, there we go. That's exciting. I like the fact that it shows an accelerometer and the percent. They tell you the percent paralyzed. They do the numbers for you. Okay, enough of that. Let me switch over. Okay, let's go to page 72. Page 72. Near the end of the last time we met 2 weeks ago, we started a local anesthetics. So let me just backtrack for a second. We didn't get very far, but we did cover a few things. Started with the names and the classification, which on page 72 is, of course, we classify them according to their chemical structure as to either ester, local anesthetics or amide, and they're listed there. We went through that. The esters are the ones that have one I in the name, and the amides have two. They all sound the same, they all end in cane, so until you get familiar with them, it's a little hard to differentiate. Page 73, I talked about the fact that in order to have local anesthetic properties or to be a local anesthetic, you have to have three chemical structural elements. One is a lipophilic benzene ring side, the other is a hydrophilic amine portion separated by the intermediate chain, either ester or amide. And I give you two examples on page 74. Page 74 at the top is lidocaine. It's the prototypical amide local anesthetic, and it has the lipophilic portion, the benzene ring, the hydrophilic portion, amine, and it's separated by an amide link, aceto-lando N. Procaine underneath that is an ester, similar to a lipophilic and hydrophilic side, separated by an ester link, C-double-lando O. So the difference between an amide and an ester link is amides have a nitrogen, esters have an oxygen. Now, page 75, we said the reason why you differentiate between esters and amides are a couple, and they're listed in the box there. Number one, the esters are metabolized by cholinesterase, and therefore they tend to be short-acting and very rapidly metabolized in the plasma if they get into the blood. The amides are metabolized in the liver by the usual cytochrome drug metabolizing enzymes. The second issue has to do with allergy, and that if people, local anesthetic allergies are pretty rare. However, if somebody is allergic, they're most likely allergic to an ester drug. And if they're allergic to one ester, they're allergic to all the esters. But there isn't not cross allergy to the amides. So if they're allergic to an ester, you can still give them an amide. As far as the amides go, allergy to any of them is rare. And if you're allergic to one, it doesn't necessarily mean you're allergic to all of them. So the amides are individual allergies. There's no cross allergy from amide to ester. So in summary, if you are allergic to a local anesthetic, it's pretty rare. You can skin test for it and find out for sure. If you are allergic, you're most likely allergic to an ester. As I mentioned, many over-the-counter products have ester-type chemicals in them, such as paramine and benzoic acid. A lot of sunscreens, cosmetics, ointments that you buy in the drugstore and so on have that in there. So people can develop an allergy to the esters without actually having received an ester drug. And then on the amides, allergy is pretty rare. If you're allergic to one ester, you're allergic to them all, but there's no cross allergy to amides. If you're allergic to one amide, you're allergic to only that amide. You can get others, and there's no cross allergy tests. And then finally, in the bottom of the box there, page 75, the ester drugs tend to be very short-acting because they're metabolized so quickly with cholinesterase. The amides are longer-acting because they have to be transported to the liver to be metabolized. So that was the background. On the bottom, nerve fiber, 75, nerve fiber characteristics and sensitivity to local anesthetics. Basically, the way it works is this. The fatter the nerve, the harder it is to block. So thin nerves tend to be easier to block than larger, fatter nerves. And myelinated are harder to block than non-myelinated, because you have to go in between the myelin sheath. So nerves that tend to be large and heavy myelination are a little more difficult to block than, for example, say sympathetics. If you see on the table, they're very small diameter, they don't have myelination, and they're blocked early in a sequence. The last thing to be blocked is usually motor nerves because they're so large and myelinated. Okay, and I think that's kind of where we left off the last time. So let's pick it up to page 77. Now, all the local anesthetics have lipophilic side and hydrophilic side, etc. On page 77, I'm highlighting this is the hydrophilic side. So this is where the amine is. And the reason I'm put it on the camera. The reason I'm pointing this out is because this amine can become ionized by attaching it to certain things. So what they're trying to show here is if the local anesthetics in the tertiary form, in other words, 3 attachments to this nitrogen, 1, 2, 3, then it's not charged, non-ionized. If this amine has 4 attachments, 1, 2, 3, and then the hydrogen ion, 4, then it becomes ionized. So the portion of the local anesthetic molecule that can ionize or not is the hydrophilic side. This is important for a reason we'll see on the next page. Oh, let's go to the next page. Now here's what happens. And I mentioned this the last time. I'll mention it again. Remember that local anesthetics are drugs you want to keep locally. Once they're absorbed, they wear off. So unlike all the other drugs we give to people, where you have to get absorbed for it to work, these are backwards. Once they're absorbed, they go away. All right? Does that really make sense? So you want to keep them in the local area. So what this little diagram is showing, and is this. Let's say I take you go in to see a patient, and the example I think I used the last time, I'll use it again, is you want to put an A-line in. Something simple. So you decide to numb up their radial artery side of the wrist, and so they don't feel a needle poke. So you give them a little injection of local anesthetic in their wrist. And so let's pretend this is their wrist, here's the skin. Local anesthetic is denoted as LA, local anesthetic. And you draw it up in a syringe and you stick it in the skin, under the skin, and you inject it. Now the local anesthetic is going to have a certain pKa, and depending on the pH that it's in, it's going to be ionized, not ionized, partially ionized, etc., etc. And that's what they're trying to show here. There's La plus H, hydrogen ion, that's in the tissues. That's your pH of the tissues. And if they combine, you end up with La plus. That's ionized. The little plus is showing charge. So the local anesthetic can exist as both non-ionized La and ionized La plus. Okay? So you took it in the syringe, you stuck it under the skin, you injected it. Now here's a nerve. This is a nerve lipid bilayer. And the non-ionized portion, there's no charge here, non-ionized portion penetrates the nerve. If the drug is ionized like this one, La plus, then it can't penetrate through lipid barrier, right? Because ionized are water soluble. Non-ionized are lipid soluble. So in order for the local anesthetic to get to its receptor, it's got to penetrate the nerve, first and foremost. So it's the non-ionized fraction that penetrates the nerve, La. La goes through the nerve membrane, gets inside the nerve, and there you have the local anesthetic. The pH inside the nerve is whatever it is, so it combines with hydrogen ion, and some of it can ionize. So it's showing here, inside the nerve, it exists as both non-ionized and ionized. All right, so let me stop and go back for a second. It's the non-ionized fraction that penetrates the nerve and gets inside. Once it gets inside, it reestablishes a new equilibrium between ionized and non-ionized. So it starts out non-ionized to get in the nerve, but then, because of the pH it's in, inside the nerve, some of that ionizes. And it's the ionized charged portion, La+, that enters the sodium channel, goes to the receptor, and produces the block. That's the end of it. Now, why doesn't the local anesthetic just go into the sodium channel from the outside? Go down there and block. It doesn't. It's too big. It's got to penetrate the nerve first. Maybe benzocaine works that way, but none of the others do. So, let's say the story. It's the non-ionized portion of the local anesthetic that penetrates the nerve, gets into the exoplasm or cytoplasm of the nerve. Then it reionizes, and it's the ionized portion that attaches to the receptor and produces the block. That's why you have to have an ionized and a non-ionized fraction or portion of the molecule, because you need both for it to get to the site and work. All right, everybody with me? Let's look at the exact same thing again. This is drawn by Frank Netter, who's a little bit better drawer than I am. He's showing exactly the same thing. He just does it a different way. Let's take a look. Local anesthetic mechanism of action. So here's the local anesthetic drug. Somebody injected it in the tissue. And there's the drug. And this part is ionized. See the drug with a hydrogen ion stuck to it? That's this one. And this part is non-ionized. There's no hydrogen ion stuck to it. That's just drug. So the non-ionized portion penetrates the nerve and gets inside. And once it's inside, it establishes a new equilibrium. It's a new compartment. And it combines with hydrogen ion and becomes ionized. So there's drug with a hydrogen ion in it, so it's ionized. Then it goes into the sodium channel, attaches to the receptor, blocks the sodium channel, and the nerve is now rendered not functional. If you can't depolarize the nerve, it can't transmit anything. So the nerve is dead. So, let's see what Dr. Netter says. Local anesthetics cause temporary loss of pain, sensation, etc. without loss of consciousness by blocking conduction along the sensory nerve. Some selectivity for pain afference is achieved by putting the agent close to the nerve. In other words, your skill as an anatomist, understanding where the nerve is, and of course we do ultrasound for that, very often too, you want to deposit it as close as you can to the nerve. So if you can do good at doing blocks, that's better. All currently used drugs block voltage-dependent sodium channels. The target site of the drugs is the cytoplasmic side of the neuron membrane. So it has to get in the nerve and then target the receptor from inside the nerve. Drug molecules must pass through the membrane. They're both lipophilic and hydrophilic in weak bases. So the hydrophilic portion attaches to the receptor, the lipophilic portion penetrates the nerve. Esters are metabolized by cholinesterase, and amides are hydrolyzed in the liver. Okay? So, when I ask you in the next test, how do local anesthetics work, you're going to answer what? They block sodium channels. Therefore, they block nerve conduction. They do it by penetrating the nerve, accessing the receptor from the inside. It's the ionized fraction on the inside that attaches to the receptor and produces blockade. Okay? Now, this little drawing, I think we did this drawing. This is from, I just want to show, and it's kind of common sense, you already know this. What happens when you inject a local anesthetic into somebody's tissue? And so, here's the syringe, of course, here's the skin. So you're sticking a needle into somebody somewhere, near a nerve, you hope, and you're going to squirt a local anesthetic into the tissue. And that's what these little gray dots are. And as they're showing here, once you inject the local anesthetic into the tissue, some of it ionizes, La+, some of it's non-ionized, La, and it's the non-ionized fraction, La, that penetrates the nerve, produces nerve block. Some of the local anesthetic, it doesn't know just to go right. The nerve's, hey, the nerve's over there, just turn right. The drug doesn't know that. So the drug spreads out 360 degrees, like dropping a stone in a pond. And so some of the drug is going away from the nerves and just being diffused off into the tissues and doesn't do anything. Some gets in the bloodstream as blood passes through these tissues and takes it uptake and removal. So as blood passes through the tissue where you injected the local anesthetic, let's say I'm doing my little wrist block for my A-line, the lidocaine I put in the wrist, blood flows into the wrist, picks up the lidocaine, carries it off into systemic circulation, and then it wears off. You get systemic tissue distribution, and it goes to the liver, it's an amide, being metabolized. If it's an ester, it's metabolized right at the site. So, that's kind of the fate of local anesthetic. Does that make sense? I mean, the point I'm trying to make is that it stays locally, you're fine. It's going to keep on working. As soon as the concentration here falls lower than the concentration inside the nerve, it goes out of the nerve and it wears off. Okay? Good. Now, let's go to page 81. We'll go through this a couple of times, but we might as well start by doing it here. This is a kinetics table for local anesthetics, and it's not that all that exciting. However, there are a couple of things I want to point out. So let's do that now. Okay, first of all, there's the pKa's of all the local anesthetics. I'm on page 81. The drugs are all basic compounds. So all local anesthetics are bases because they contain nitrogen. They're all basic. Your pKa's range from 7.6 up to about 8.9. If you look on this table, that's about the range. So here's a phenomenon that happens. This is the point I'm trying to get to. The onset of action of a local anesthetic, how fast it works, one of the most important parameters determining the onset of action of a local anesthetic is its pKa. The lower the pKa, the faster the onset. The lower the pKa, the faster the onset. Now, by lower, I mean the closer it is to 7.4. That's the bottom. So the lower, when I say that, what I mean is, the closer the number is to 7.4, the faster the drug. So looking on this, which one is close to 7.4? Mepivacaine, carbocaine, that's 7.6. So its pKa is close to body pH 7.4. If the pKa of the drug equaled the pH of the solution, if the pKa of the drug was 7.4, let's just pretend my new local anesthetic I just made, it has a pKa of 7.4, how much would be ionized or non-ionized in tissue? 50%, right? So when they're equal, it's 50-50. So the reason that the pKa determines onset is because the closer it is to pH 7.4, the larger fraction that is non-ionized, and in order to penetrate the nerve, it has to be non-ionized to get inside the nerve. So it works faster if it's not ionized initially. That's it. Make sense? Now, there's an exception. There's always an exception. This is the exception. Look at chloroprocaine. Chloroprocaine has a pKa of 8.7. You would expect it to be relatively slow, but in fact, it's the fastest local anesthetic we have. It's Nesicaine, chloroprocaine. How come it's the fastest if it has a very high pKa? That's because we give it in a high concentration. We give 3% concentration. Unlike, say, bupivacaine, where you're given 0.5%. So you're giving it in such high amounts that it makes it work faster. But that's the exception. So let me say it all again one last time. What the pKa of a local anesthetic has to do with is onset. And the closer the number is to 7.4, in other words, the lower it is, the faster the onset. The exception to that is chloroprocaine, because we give it in such high amounts, high concentrations, then it overcomes any issues and becomes fast acting. Okay, everybody with me on that? All right, let's go to the last column of the table. That's protein binding. We already know all about protein binding with the local anesthetics. What protein binding has to do with is duration of action. The more protein bound a local anesthetic is, the longer the duration of action. That's it. Done. The more protein bound, the longer the duration of action. Why? Because if it binds strongly to proteins, it's probably binding strongly to tissues and nerves that it's in, and therefore it takes longer to release it. So it just makes it last longer. So what would you anticipate would be the long-acting local anesthetics? Well, bupivacaine, 95% protein bound, etivicaine, 94, ropivacaine, 94, etc. So, to get off of this page, let's summarize. As far as kinetics of local anesthetics, the pKa makes a difference with onset. The closer the pKa is to 7.4, the faster the onset. The exception is chloroprocaine with a high pKa, even though it's fast. As far as duration of action goes, the parameter that helps determine that is protein binding. And the more protein binding there is, the longer the duration of action of the agent. So bupivacaine and ropivacaine are long-acting. So they're highly protein bound. Okay? Any questions? All right, let's take a look at the next page, 82. Now, what I want to do is talk about adding vasoconstrictors. Why do you add vasoconstrictors in with the local anesthetic? What does it do? And, yes. So, what is it? Adding vasoconstrictors does the following. It's kind of common sense. If you constrict the blood flow to the area you put the local anesthetic in, then it won't be removed as quickly because there's less blood flow, and it'll last longer. And of course the surgeons do it. They put vasoconstrictors in there to have less blood flow to the area so they don't get as much bleeding. So in very vascular procedures, head and neck, a lot of plastics cases, etc., scalp when they're doing craniotomy, before they do the incision, they'll inject epinephrine in the skin to cause vasoconstriction so they don't have as much blood loss. It doesn't bleed as much. So that's easy. Let's take a look at this. This is a chart on page 82. They're looking at, well, what happens if I just give more local anesthetic, increasing the dose, or what if I the same dose but add epinephrine or a vasoconstrictor in with it? All right. What happens to the onset time? Well, if you give more, the more you give, the faster it works, right? That's basic pharmacology of any drug. So if you increase the dose of local anesthetic in the first column there, then you decrease the onset time. A shorter onset time means the drug worked faster. Right, that's how to make it work faster. It can be confusing. The onset time of a drug goes down, that means it worked faster. If you increase the dose, it works faster. Well, we knew that from last September. Right, if you add epi, it also works faster. Except for spinal anesthesia. We'll talk about that in a second. But if you add epi, it makes it work faster. Why? Because more of it stays locally where you injected it. There's not as much blood flow. So there's a higher concentration where you dumped it with your syringe. Therefore, higher concentration, it works faster. That's except for spinals, and you see my little asterisk there. For some reason, I don't know why. Somebody probably does. When you do a spinal, you put epi in it, it makes it onset a little bit slower, a couple minutes slower. And you've probably done that already, right? All right, the degree of motor block, if you increase the dose, you get a wider block. Same with you put epi in it. Sensory same, the duration is longer. When you add epi into a local anesthetic, it makes it last longer. That's one of the reasons, main reasons, why we do it. If you want your block to last longer, put epi in it. Because then it basically constricts the area you have the local in. It doesn't get removed as quickly, and therefore it doesn't wear off as fast. The area of blockade is higher, and of course, if you give a higher dose, you get a higher plasma concentration once it's absorbed. But with epi, if you give epinephrine, you get a lower plasma concentration because it doesn't get absorbed as quickly, it stays in the local area longer, therefore the blood level never gets as high. So if somebody asks you clinically, one of your preceptors as you're doing such and such a block, well, why do we put epi in there? Your answer is going to be make it last longer and to decrease the toxicity. It's not as toxic if it doesn't get absorbed as quickly. Because what causes toxicity? Local anesthetics. High blood level. If you can keep the blood level lower, then you have less toxicity. So you can take a look at what I wrote on the bottom, page 82, but I'll just say the beginning. Vasoconstrictors, epinephrine, primarily. 5 mics per ml, or about 1 to 200,000, is frequently included local anesthetics. And the company makes them. You just put them off the shelf. It's already prepared. Lidocaine with epinephrine, or whatever, bupivacaine with epinephrine, you name it. So we don't have to mix these. but that's the concentration they was leaving. Now on the bottom of the page, I also mentioned about other additives, and it's certainly some people use clonidine in their blocks. They say it makes it last longer. Some people put steroids in them with their block. They say it makes it a better block. Very often, almost all of us do opiates, put a little fentanyl or something in with a block for analgesia. That makes it nice, smooth block. So you can add other additives as well. Okay, let's take a break. Okay. Now this is has to do with the maximum safe dose of local anesthetics. So let me give you this background, don't write. First of all, you can't do studies to look at local anesthetic toxicity, because you can't go to somebody and say, let me give you more local anesthetic than you can handle, you can have a seizure, then I can determine, obviously that's silly, you're not going to do that. So the information that we have is usually anecdotal, because somebody accidentally got an overdose. Somebody did a case report on it. Or it's animal studies, which aren't always attributable to human. So, although we know a lot about it, we don't know the exact amount that you can give or not give. Right. The other factor, that's probably the most important factor, is it depends on where you inject it. So let me see what I mean. Let's say I take 1% lidocaine, 10 mLs, and I inject it in a rib block. So we're trying to do something for the incisional pain, so the surgeon injects it before the patient wakes up. They wake up with a little block of their incision on the side, and they can breathe deeper for the first 24 hours, and it's all wonderful. Let's take a look if I gave that same 10 mLs of 1% lidocaine in an ankle block. Which one's going to result in a higher blood level? Well, the rib block is going to be higher. Why? Because there's so much vascularity in the rib area. Between each rib, there's a nerve, artery, vein. So you got a lot of blood flow and blood absorption coming out of these rib blocks. Down on the ankle, there's not much vascularity. You can inject local anesthetic the same amount. You're going to end up with a much lower the blood level than you are for the rib block. And what the blood level is what determines whether you get toxicity or not. The lower the blood level, the less toxic. So you can put the same, my point is, you can put the same concentration and amount of local anesthetic in different parts of the body and end up with different blood levels, just due to the vascularity of where you put it. It also matters whether you're injecting in a vessel or not. Of course, we're going to talk extensively about toxicity here in a few minutes, but the number one cause of local anesthetic toxicity is you're accidentally injecting in a blood vessel. You think you're doing a block, and instead you're giving an IV, intraarterial or whatever, and you're going to end up with a high blood level. So, with all that in mind, a lot of people have said, well, you can't really learn one dose, that's the maximum dose, because it depends. It depends on the patient, it depends on where you're doing the block, whether you use ultrasound to make sure you know where you're injecting, and and so on and so forth. If you go to the next page, page 84, I took this is an older one, but there's an editorial about every 2 months in some journal talking about abandoning blanket maximum doses of local anesthetics. In other words, let's not learn that the maximum safe dose of lidocaine is 7 milligrams per kilo, because it depends on where you put the lidocaine. It's safer in non-vascular areas, you can probably give more than you do in vascular areas, etc., etc. So this gent here in this editorial, and like I said, there's a million of these editorials, and you see them all the time. But I'll just go to the last paragraph, and he says, unquestionably, technical skill is one factor that determines how much local is needed to produce a block. Research aimed at defining the most effective way to teach and acquire technical skills is important. A single blanket maximum dose of local anesthetic to avoid toxicity is neither scientifically valid or clinically relevant. Okay. So, and this is what we're talking about. Let's pretend, and I'll just say this to give you an example. Let's pretend you're going to do a brachial plexus block. Somebody's having arm surgery or hand surgery or whatever, elbow surgery. You're going to numb up their arm. So you're going to come and stick local anesthetic into their axilla and numb up all the nerves in their arm. Well, you got to put a lot in there because you got a lot of nerves, right? Radial, ulnar, muscocutaneous, etc. You got a bunch of nerves you got to hit. You want to stick it in the sheath and fill it all up with local anesthetic. So you try to give a large volume. So this is an issue when you're giving large volume blocks. So let me go off on a tangent to mention. For example, if you're doing a spinal, you're never going to get an overdose of local anesthetic from a spinal. Why? Well, what's the most bupivacaine you give in a spinal? What those vials have in them. You give spinals, what is it?
2 cc.
Yeah, how much is that? How many milligrams?
8.
15, correct. So you're giving 15 milligrams of bupivacaine for the maximum spinal effect. Well, I could give that IV push and it wouldn't get toxicity, it's down on it. It's just a tiny amount, right? Because in the spinal, you're putting the drug right into the cerebrospinal fluid. It's bathing the nerves right there. Then you don't need to give high concentration. So you're not going to get an overdose from doing a spinal. You may end up getting a high spinal or something like that, but that's a different story. So this only pertains, my point is, when you're giving large volumes of local anesthetic because you're trying to block a large area, sciatic femoral, or you're doing an abdominal block for excision, a tap block, axillary block, whatever. You want to give the maximum amount. So here's what happens. Let's pretend I'm going to do an arm block. I'm going to use lidocaine. I'll stick with that. I'm going to give 1% lidocaine. And I know the maximum safe dose of lidocaine is 7 milligrams per kilo. And this patient I'm going to do the arm block in is conveniently 70 kilos. This gentleman. So how much lidocaine can I give this patient? Well, the maximum dose is 7 per kilo. And I just said he weighs 70 kilos. So you can give 490 milligrams, right? I'm using 1% lidocaine, which is how many milligrams per ml? 10. So then I can give 490 milligrams. So how many mLs can I give? 490 divided by 10, you're correct. The answer is 49. So I could give 49 mLs of lidocaine for the brachial block, and I should be within safe limits. So everybody see what you're doing, why we're doing this? So, but the guy says here, well, we shouldn't be doing these maximum doses. Here's my response, all right? You're a student. You're going to work and do a brachial block, and your preceptor is going to go, how much local anesthetic you're going to give? And you're going to say, oh, let's stop worrying about that. I want to see an editorial that I don't even want to talk about it. We'll just do the block, and we'll not worry about how much we give. And of course, you'll be in my office in about 3 minutes. So maybe somebody's going to abandon it, but it's not going to be you. So you're going to memorize these numbers so that when your preceptor says, how much can you give, you're going to give them an answer. They're going to be happy, and you're going to have a much nicer student career than otherwise. Now, these aren't exact scientific. As I said, we don't have good studies. A lot of my animal studies are just anecdotal case reports, but we do have a certain ballpark figure that we know is you stay below this and you shouldn't end up with too high a blood level when it gets absorbed into the bloodstream. And so let's take a look at page 83. The number in parentheses is with epinephrine. The number not in parentheses is without. Now I'm saying let's just learn one number for each. We'll do the with epinephrine number, because chances are if you're going to use large volume, you're probably putting Epi in there. So procaine, Novocaine, the dose is 14 milligrams per kilo. Chloroprocaine is the same. Tetracaine, 1 milligram per kilo. Tetracaine is the most toxic local anesthetic we have. Fortunately, we don't give it very much anymore. We use it topically a little bit, or once in a while we can do a spinal with it. We don't really do that much anymore, but we only give small amounts. Cocaine, it's 200 milligrams total by topical administration. Lidocaine is 7, bupivacaine is 7, Prilocaine is 8.2, and then bupivacaine and ropivacaine, you can just use 3 for each. Just make it easy. So I'll say it again. Procaine 14, chloroprocaine the same, tetracaine 1, cocaine 200 milligrams topically, lidocaine and mepivacaine 7, bupivacaine and ropivacaine 3. Memorize those numbers. I'm asking them the next test. Then when your preceptor asks you, you'll be able to give them a number and they'll say, no, it isn't 7, it's 8. Just to give you a hard time. Okay? Good. Now, let's go to page 85. Let's talk about iron trap. This is going to make your brain tired, so go slow. The term ion trapping is kind of a slang term that's used to talk about some phenomenon that can happen in the body when you give local anesthetics, having to do with pH and pKa. So let's go through some of these. Bullet number 1, I'm on page 85. In the event of a local anesthetic overdose, so let me explain this one and then we'll just read it. If you have somebody that overdoses from a local anesthetic, let's pretend you're doing a brachial block and you're going to give 43 mLs of Lidocaine. And we're going to talk again a great deal about toxicity. But let's pretend you get in 15 mLs into the injection and the patient all of a sudden starts to seize. You're obviously in a blood vessel by mistake. You're giving it straight IV. The patient's going to have a seizure. They're overdosing. If somebody has a seizure, then they can get hypoxic if they're not ventilated properly. And if they get hypoxic, then they, of course, will, as you all know, being ACLS and PALS, etc., critical care nurses, they can get acidotic. Hypoxia can lead to acidosis. So if the patient overdoses, seizes, becomes acidotic, which is the natural thing that happen, then when they get acidotic, the pKa of the local anesthetic never changed. That's constant. But it's in a more acid environment. So then what happens? You got all this local anesthetic in the brain. You want to get it out of there so they're not toxic anymore. The brain becomes more acidotic. The local anesthetic's a base and a more acid pH. What happens to it? It ionizes, right? The more ionized it is, it can't pass the blood-brain barrier to get back out again. Right? We're always talking about going through the blood-brain barrier to get drugs into the brain. But this is an example of trying to get drugs out of the brain. Same phenomenon. You can't do it until you get rid of the acidosis. So the fact that the patient gets acidotic makes the toxicity worse. You better hurry up and resuscitate. We'll talk about that. So let's read what I wrote. Top of page 85, bullet number 1. In the event of a local anesthetic overdose, associated respiratory depression may occur, resulting in hypoxia and acidosis. The acidosis resulting from the hypoxia may increase the ionized fraction of the local anesthetic within the cerebral circulation. Therefore, it decreases its ability to cross the blood-brain barrier and get out, leave the brain, and re-enter systemic circulation. This phenomenon can prolong and enhance the CNS toxicity of a local anesthetic. That's one issue with pH and pKa. Local anesthetic overdose. Does that make sense? If not, I'll be glad to say it again. All right, let's go to bullet number 2. Local anesthetic accumulation in fetal circulation is enhanced by the fact that fetal pH is lower than maternal pH. So in a pregnant woman, who you're giving local anesthetics to, we do that millions of times a day, doing epidurals in pregnant women for deliveries and so on, sections. The fetus has a more acidotic pH than mine. Therefore, theoretically then the anesthetic is going to accumulate in the fetus because of the more acidotic pH. So I'll read it. Local anesthetic accumulation in fetal circulation is enhanced by the fact that fetal pH is lower than maternal pH. This may result in high fetal levels of local anesthetics. Let's take a look at the top of the next page, 86. I've got a little figure here to show you that. This is plotting the lidocaine, lidocaine concentration. This is lidocaine concentration in normal fetus, acidotic fetus. Then they corrected the fetal pH with bicarb, and it went back to normal. In this experiment, these are probably rats or mice or something, and you can see that when the fetus is more acidotic, the blood level of lidocaine in the fetus goes up. Because when the lidocaine passes the placental barrier, gets in the fetus is more acidotic, therefore the lidocaine ionizes, and the more ionized it is in the fetus, then it can't get back out into mom's circulation and be eliminated. So you can see the more acidotic the fetus gets, the higher the concentration of lidocaine would be. Make sense? Now, is that clinically relevant? No. Probably not. You don't give that much. First of all, for epidurals, for deliveries, and so we give a decent dose, but not enough to cause maternal toxicity. There's no reports of babies being delivered with low APGAR scores because of the epidural, local anesthetic. So it's really kind of an academic thing. Nonetheless, it's there. I don't think it clinically matters. Okay, number 3rd bullet on page 85 then. What happens if the patient has an infection? Patient shows up in ER and they get their hand and they hit their hand with a hammer 3 or 4 days ago, and now it's all swollen up and it's hot and there's pus draining out of it and it's infected and they want you to fix it. Drain it, debride it, wash it out, put a Band-Aid on. So you say, okay, I'll inject some local anesthetic into that infected area, numb it up so I can wash it real good, well, and clean it up. Well, you inject a local anesthetic and it doesn't work. Why not? Because local anesthetics don't work in acidotic tissues. Why? Let's read. Bullet number 3, page 85. Local anesthetics injected into acidotic infected tissues are rendered ineffective due to the loss of lipid solubility. So think about it. You stick a local into somebody's hand, for their infected hand, and the pH in that tissue is lower because it's infected and it's acidotic. So the local anesthetic's in a very acid tissue. It's more ionized. The more ionized it is, then it doesn't have the non-ionized to penetrate the nerve. And it can't get inside the nerve, so it can't work. That's it. Simple. Let's read it again. Local anesthetics injected into acidotic infected tissues are rendered ineffective due to the loss of lipid solubility. Lipid solubility of local anesthetics is diminished in an acidotic environment due to the increased concentration of the ionized water-soluble form of the drug. The loss of lipid solubility prevents absorption into the nerve, thereby preventing access to the site of action. So, acidotic tissues you can't inject local in, they don't work. They're very spotty at that. Right? Make sense? Number 4. You having fun yet? Alright. What about carbonated local anesthetics? People in Europe, they do this still. In the US, they don't bother. But they've done it over the years. Just put CO2 into the vial, local anesthetic vial, that you draw up and inject. What about carbonating local anesthetics? Well, here's what happens. If you add CO2, then the CO2 gets, well, let's read it. Carbonation of local anesthetics speeds the onset and intensity of action of neuroblockade. Carbon dioxide readily diffuses into the nerve. So what happens is this. The CO2 you put into the vehicle, the vial, you draw it up in a syringe, inject it. The CO2 goes in, gets absorbed into the nerve right away. It makes the inside of the nerve more acid. So when the local anesthetics get in the nerve, they're in a more acidic environment, so they ionize more. The more ionized in the nerve, the more it attaches to the receptor, the faster it works. So carbonating speeds the onset because it makes the inside of the nerve more acidotic, which increases the fraction of the ionized portion, making it more susceptible to attaching to the receptor. So carbonation of local anesthetic speeds onset because of making the inside of the nerve more acidotic. Is everybody with me on that? We got one more. And you can put your brain to sleep. Last one. What about adding bicarb to local anesthetics? You might have seen that already. Some people you work with. I know the military hospitals, they do this quite a bit. Their blocks. You go down to the Navy Hospital in San Diego, they do that. What if you added bicarb to the local anesthetic? What does it do to it? Well, here's what happens. Convert on the last bullet on the bottom of page 85. Commercially available local anesthetics are prepared in a slightly acidic formulation, which improves the stability of the drug by increasing the concentration of ionized water-soluble form. So what they're saying is when you pick up a bottle of lidocaine out of the drawer, the solution that it's in is kind of buffered to the acid side. Because the local anesthetics are bases and they're in an acid solution, they're going to be more water-soluble and they're not going to clump up and form nasty stuff in the bottom. So they're kind of acidic. If you add bicarb to the local anesthetic mixture and increase the pH of the solution that it's in, then the local anesthetic's in a base, and now it's in a more basic solution because you put bicarb in it, then what would happen? Would it be more ionized or more non-ionized? It's a base in a more basic solution. Non-ionized, right? And if it's more non-ionized, then it can penetrate the nerve better and it can work faster. So, keep reading. The addition of sodium bicarb to the local anesthetic mixture increases the pH of the solution, increasing the concentration of non-ionized lipid-soluble form of the drug. This improves the lipid solubility and diffusion into the nerve, therefore a more rapid onset of action. So adding bicarb to local anesthetics speeds onset because it makes more non-ionized portion outside the nerve. It's able to penetrate the nerve even better. Adding CO2 speeds onset also. That's because it makes the inside of the nerve more acid. Bicarb makes the outside of the nerve more basic, both leading to a more quick onset. Make sense? You'd say yes no matter what. Now, does it work? I don't think so. Probably not. Some people think it does. It helps a little bit. One of the problems when you do blocks, other than spinals, is you gotta wait for it to work. And sometimes it takes 20, 30 minutes to work. So it's gotta diffuse through all those tissues into the various nerves, especially if you're trying to do multiple nerves. So it could take a good half an hour for the block to work. So anything we can do to speed it up, of course, is better, because you know this performance and speed pressures that go on in an operating room. You gotta hurry up, etc. So adding bicarb to it, I'm not sure. The studies have been kind of yes, no. Some say it speeds it up, some say it doesn't matter. The people who do it think it speeds it up, and that's fine. It's pretty harmless. I think most of what it does is this. If you've ever had an injection of a local anesthetic, it kind of stings for about 5 seconds after they first put it in. So you put the needle in, and you inject lidocaine, or whatever local anesthetic. And you get this like sting feeling for about 5 seconds, and then it starts to get numb. The bicarb takes away the sting. So patients tend to tolerate the injection a little bit easier. So that's that. Those are 5 issues with pH and pKa that can influence the behavior of local anesthetic solutions. Okay? Let's look at the next page, 86, bottom table. Here's the reference I got this from, and I'm just repeating myself, so why not? So, characteristics and clinical correlates. What about local anesthetics? Characteristic, lipid solubility. The clinical correlate, it has to do with potency. The more lipid soluble a drug is, it enhances diffusion through the neural membrane, cell membrane, and allows you to give a lower milligram dose. So more lipid soluble means it penetrates the nerve better. It's probably going to be more potent. The dissociation constant, that's the pKa, dissociation constant, has to do with onset. We already mentioned. That helps determine the portion of the administered dose that stays in a lipid-soluble tertiary amine state. Agents having a lower pKa have a greater proportion in the non-ionized state, therefore hastening onset. All right, number 3, esters or amides, the chemical link between the two sides. There's ester and amide. Well, that has to do with metabolism. The correlate clinically is metabolism. Esters are metabolized by cholinesterases, and amides are biotransformed in the liver. And finally, protein binding. What does that have to do with local anesthetics? It has to do with the duration. Ability for plasma proteins also corresponds to affinity for protein at the receptor within the sodium channel. prolonging the presence of anesthetic at the site of action. So the more protein bound, the stronger the binding will be everywhere, including at the receptor. That's an indicator of the strength of receptor binding. The more it's bound, the longer it's going to last. So these are the little parameters that have to do with the clinical aspect of effective local anesthetics. Lipid solubility has to do with potency. The pKa has to do with onset. Whether it's an ester or amide has to do with metabolism. And protein binding has to do with duration of action. Okay, any questions about that? All right, let's go to page 87. Next page. All right, let's talk about local anesthetic toxicity. The powers that be in anesthesia have designed the word LAST, L-A-S-T, to coin a term for local anesthetic toxicity, local anesthetic systemic toxicity, LAST. So this is LAST. And so let's talk about it. Don't write anything down, just let me talk. Having a toxic reaction to a local anesthetic can be a major issue. And it occurs because you get too high blood level. Now, it's not going to happen when you give an ester. The half-life of chloroprocaine, just, the hell of it, the half-life of chloroprocaine is about 59 seconds in the plasma. So what's the chances of getting a blood level of chloroprocaine high enough to cause toxicity? It's gone so fast that it's metabolized so quickly it's never going to happen. So the esters, you don't really worry about systemic toxicity because of their rapid metabolism, no matter where they are in the body with cholinesterase. So it's the amides. And if you give an amide, it has to be absorbed into the blood, taken from the area of local injection, and then transported to the liver to be metabolized, so you can get a high blood level if you give too much. Most people think that if you get a systemic toxicity from a local anesthetic, you're most likely injecting in a blood vessel without knowing it. I tend to think they're correct, although you can, in fact, give too much local anesthetic. If you exceed those numbers, we're going to learn. I've had 2 cases in my life practice, and in both cases, I swear up and down, I was not in a vessel when I was injecting, but I was and didn't know it. Fortunately, we were able to recognize it immediately, treat the patient immediately, and they didn't go into a full-blown overdose situation. The patient did fine. They woke up 15 minutes later and said, "Oh, what happened?" That was no big deal. So if you handle it properly, it's no big deal. The only time it is a big deal is if you let things get out of hand. For example, you don't ventilate the patient and they get hypoxic, or you have them seize too long and they get hypoxic or whatever. We'll talk about it as we go along. So the fact that the patient had an overdose of local anesthetic in and of itself doesn't really matter. They can do fine as long as you handle it properly. And we'll learn about handling it properly. It's basic common sense. Now, for many years, in fact, when I was a student, we memorized this here on page 87. So let's take a look at this for a second. I'll go on the camera. This is the common wisdom. It was always this was what we learned. What they're plotting in this graph is These are blood levels of lidocaine from 0 to 25 mics per ml. And these are systemic effects you see. And so they're saying as long as your blood level is below 5 mics per ml, that's therapeutic. Patient's going to be fine. You've all given lidocaine IV, right? For various reasons. And so what you're trying to do is get somewhere near 0 to 5. That's therapeutic. When the blood level exceeds about 5 mics per ml, then you start to see these increasing signs of overdose. So what happens first is the patient, we all memorize this. So the first thing, once you get up to your around 5 mics per ml, you're right on that line, the patient starts to get some CNS excitation. See lightheadedness, tinnitus, ringing in the ears, circumoral and tongue numbness. They feel like numbness around their mouth. Their tongue feels like it's big. You ever go to the dentist and get injected, your side of your face seems gigantic? Well, that's how their tongue starts to feel big. They get a metallic taste in the mouth. They know something's weird. They're kind of getting a little bit agitated and lightheaded and excited, etc. And that happens when you start to get around 5 mics per ml. Then, when you go blood level higher, you start to see double vision, visual disturbances. Then you get a little higher, you see some muscle twitching. Looks like fasciculations, like that lady in the movie this morning. You see her face fasciculating? That's what it looks like that's what the thing I noticed with both of the cases I had. Muscle twitching. Then, eventually, you get seizures. So let's talk about it. First you see it. What happens when the blood level of lidocaine is going up? This arrow is saying the blood level is going higher and higher and higher. At first you see a little bit of excitation followed by severe depression. Well, that's disinhibition. Remember that from Signs and Stages of Anesthesia last semester? The brain's going to sleep. Local anesthetics are depressants. You're putting the nerves in the brain to sleep. The deeper the patient goes, you see a period of excitement stage. Meaning lightheadedness, confusion, muscle twitching, seizures. They're all excitatory responses, aren't they? Well, you're telling me you're giving a depressant drug, why are you getting excitatory responses? Well, it's the same old, it's disinhibition. You're putting to sleep the inhibitory portions first before the excitatory part of the brain. That's why you see the excitement stage when you put someone to sleep with a gas anesthetic. Everybody with me? Once you get through the excitement part, seizures, the seizures are self-limiting. Let's pretend I took somebody and I laid them on a table, I started an IV and I just injected a very high amount of local anesthetic, just so I wanted to see what would happen. And what I'd see, the patient get a little restless and lightheaded, tinnitus, ringing in the ears, metallic taste in the mouth, confused, boom, seizing. Patient would seize for a minute or two and then stop. The seizures are self-limiting. They'll stop when you get through the excitement stage. Then you get into stage 3 up here. And then if you let it go far enough, stage 4. So the seizure will stop, they'd be self-limiting, and you end up with a very profoundly unconscious comatose patient. Just like if you're given gas. Now they're in stage 3. They don't have any reflexes, they have any protective reflexes, etc. They right in here unconscious and coma. Well, that's pretty much stage 3 to me. And then if you let it go even higher, they'd get a respiratory and eventually a cardiac arrest. That would obviously be stage 4. So that was the classic we all learned for 40 years. Then along came bupivacaine. Here's what happens. bupivacaine was the first really long-acting drug, and it was very exciting because you were able to give a local and have it last a long time. If you want to block somebody for 8, 9, 10 hours, or even longer sometimes, you could. So that was a good thing. But here's what happened. In England, they decided to do this. You know what a beer block is? Has anybody ever talked to that? IV regional? Well, for those who may not know. There's a block you can do called an IV regional or beer block after the guy's name, Dr. Beer, not the beer you drink. And you put a cuff on the patient, you start an IV, you fill it, drain the blood out of their arm, you fill the veins with local anesthetic. And the local anesthetic diffuses from the arm veins into the tissues and causes the arm to be numb. So it's a simple block. You can be an absolute expert if you can start an IV. That's all you got to do. You just start an IV. Inject 40 mLs of lidocaine in there. In the United States, we always use 40 mLs of 0.5% lidocaine. They even make vials just for beer blocks with 40 mLs of 0.5% lidocaine. Everybody in America uses the same dose, the same drug, no matter what. The reason is, first of all, how many milligrams is 40 mLs of 0.5% lidocaine? 200 milligrams, right? So that's safe. That's not an overdose. And so that was cool. And secondly, the beer block can only last 2 hours, no matter what drug you give. It's only going to last 2 hours. Why? Because you got to put the tourniquet down. You can only keep a tourniquet on for 2 hours. So the drug isn't as important as the fact that you got to put the tourniquet down. Now you can't give an ester because it'll be metabolized right in the arm and it'll only last a few minutes. But you can use an amide, and that's why we just use lidocaine, might as well. Because then after 2 hours when you put the cuff down, it's absorbed systemically. 200 milligrams of lidocaine isn't that much. After a couple hours, a lot of it stays in the arm initially, so it's not really blasting out into the systemic circulation, and the patient does fine. In England, they decided to do this. They decided they would use the highest concentration. At that time, it was 0.75%. 0.75% bupivacaine. We say, well, why would they use bupivacaine, an 8 or 9 hour drug, for a 2 hour block? You got to put the tourniquet down, right? And they thought, well, yes, that's true, but then maybe some of the bupivacaine would stay in the arm when you took the patient to the recovery room, and when they got dressed and went home, and they'd be a little bit numb the rest of the day, and they'd have some post-op pain relief. So what a great idea. So they gave 40 mLs of 0.75% bupivacaine, put the cuff down after 2 hours, and these patients went into cardiac arrest and died. And that was a number of patients. They had in the teens before they realized. So then now we have to go study all this, right? Let's jump up to 2018 and figure out what happened. What happened was this. We now know, we didn't know at the time. Bupivacaine has a special binding ability to certain cardiac proteins. It binds in the heart preferentially over any other tissue of the body. So when they put that cuff down for the beer block and let the bupivacaine go systemically, it went to the heart, it bound to cardiac proteins, and you couldn't get it out of there. It caused cardiac arrest. And you couldn't resuscitate these patients. They did CPR on them for hours. They put them on bypass machines in the cardiac rooms and tried to filter their blood that way. And it just was not a pretty picture. So we've learned a couple of things. Number one, don't use bupivacaine for an IV regional. That was pretty easy to take that lesson home. Secondly, the FDA in the US outlawed 0.75% bupivacaine. They said it was too strong, you don't need it. They only use 1/4 or 0.5%. And we knew that bupivacaine has a special cardiac toxicity that's different than all the other drugs. Because what happened was, when those patients overdosed the first thing that happened is they cardiac arrested. They didn't go through this lightheadedness, seizure, coma thing. It wasn't CNS first, then cardiac, etc., just like we were always taught. These patients went, boom, cardiac arrest. No CNS signs whatsoever. And you resuscitate them and beat on their chest and put them on bypass and did all you could do, and you could not get this drug to leave the heart. So that was a problem. Now, ropivacaine is the R isomer of bupivacaine, and that's the same duration, long-acting, but it doesn't have the cardiac toxicity that bupivacaine has. That's where that came from. It's trying to come up with a bupivacaine drug that didn't stop the heart. But that's the story behind that. So we learned that, first of all, you can overdose from a local anesthetic and not go through this classic CNS first, cardiac last pattern. You could, in fact, sometimes cardiac arrest first before anything else. So watch out for overdose. I'll teach you what to watch for and all that after the break. And that bupivacaine has special cardiac toxicity that the other drugs don't seem to have. All right, let's take a break. Okay, let's turn to page 87. 87. So again, just to repeat, this page 87 is the classic pattern, supposedly, of local anesthetic overdose with CNS symptoms first, followed by coma and respiratory cardiac arrest. So once bupivacaine became known as being cardiotoxic, the American Regional Anesthesia Society decided to go back and take a look at all overdoses and just try to give it a clearer pattern. And so they went back and looked at every case in the literature that they could come up with that describes a local anesthetic overdose, and they've re-upped or did the more modern version as well. And I have the numbers and the data and the studies in my chapter. But if you go to page 89, this is kind of what they found out. Page 89. So they looked at all the local anesthetic overdose scenarios that were reported, and it was over 100. And this is what they found out. Those reporting a CNS signs and symptoms first, in other words, confusion, restlessness, tinnitus, etc., was about 45% of the time. People having just a cardiac event, in other words, just cardiac arrest, to having arrhythmias, boom, arrest, was about 11%, and about 44% had both CNS and cardiac signs at the same time. So they didn't have CNS followed by arrest, they had them both at the same time. So you can look at just about half and half had a combination of either CNS alone or CNS and cardiac together. So it's a little different than we were always taught. That yes, if they have CNS signs, that's the way they'll progress. But it doesn't mean that's the only way that you can see an overdose in a patient. Let's take a look at the next page, page 90. Of patients who have CNS signs and symptoms, this is what they see most commonly. And 18% of them, they started with dizziness, drowsiness, tinnitus, the confusion, dysphoria, etc. Then lost conscious, 7%, agitation, 11%, and people just having a seizure outright, first and foremost, 68%. So that was the most common CNS finding. And that's kind of scary. On the cardiac signs, next page 91, These are the cardiac events that can happen in all those overdose situations, and you can see, and I won't go through each one of them, but they can have cardiac arrest, bradycardia, just about anything you can imagine. Hypotension, ventricular arrhythmias, etc., etc. All kinds of arrhythmias, including cardiac arrest. So pretty much a lot of bad things can happen with local anesthetic overdose, either CNS, cardiac, or both. Now, what I found interesting in all this, the next page, 92, was this little small reporting that was done in their study, and that is, when does it occur? If you're going to get a local anesthetic overdose, when does it happen? And take a look. The biggest proportion, that's the percent, these little bar graphs on page 92, 50% of the time it occurred less than 1 minute after you injected, or the same time you're injecting. So if you're going to get a local anesthetic overdose, it's going to happen fast. Less than 1 minute. So, and that's, both of mine happened. We were still injecting the block, doing the block, and the patient's already getting a little restless, and I feel funny, and I'm dizzy, and then boom. We just took care of it right away. 1 to 5 minutes, it was about 25%. 5 to 10 minutes, a little bit smaller, about 10%. And then greater than 10 minutes, this is usually something on the ward who's getting IV infusion, long-term infusion of local anesthetics for pain. That may have some 24 hours later, whatever. That's small. As far as us doing blocks, you can see within the first 5 minutes after you inject, it was about 75% of the patients. So if you're going to get a local anesthetic overdose, it's going to happen fast. Because most of the time it happens because you're injecting in a vein, and that's going to happen fast. So I thought that was kind of interesting too. So let's go to page 93. They've come up with what they would like to recommend as ways to prevent, recognize, treat, and so on, various last scenarios, and we'll go through these. But first of all, let me say this, very important. You never do a block on somebody without an IV in. You have to have an IV in before you do the block. Because if you're going to get an overdose, it's going to happen within a minute, 50% of the time, and you're not going to have time to, while the patient's in the middle of seizing, to stop and start an IV. It's stupid. So you got to have an IV in. You have to have all proper resuscitative equipment available immediately within arm's length. You're not going to be able to say, "Hey Mary, would you run down to room 5 and grab me a laryngoscope?" Because this patient is going to seize and be in a coma well before Mary gets back from room 3, whatever. So you got to have the stuff around. Most departments, in fact I would imagine all departments that do any significant amount of blocks, will have like a block tray or a block kit or whatever that you can take to the bedside if you're doing the block in the pre-op holding area early so that it'll start working by the time you get back in the room. You can have resuscitative equipment available right there in that little block kit. It has to have various airway equipment. You know the drill. You got to have oxygen available to give oxygen. So just the usual stuff. Now you'll see as we go through this, and let me go off and let me just talk for a minute. You'll see as we go through this, basically what this is just ACLS. It's just airway, breathing, circulation. That's all it is. If you're going to treat somebody with an overdose with local anesthetic, you want to establish an airway first and foremost. Number 2, you're going to make sure the patient's breathing, and then 3, handle the circulation part of it. So it's just the ABCs. You already know all this stuff. Right? We're just going to talk about it in maybe a different way a little bit. So that's how you treat a local anesthetic overdose. This is Anesthesia 101. Every CRNA and anesthesiologist in the world has to know this. This is the basic practice of anesthesia. If you're going to do a block, you got to know how to prevent overdoses, or if it, God forbid, does happen, then you know how to treat it so the patient's safe and it ends up being okay. One of the things I was taught, and I'll just mention this and we'll go through this, there's a question that goes on. Let's say I get an overdose, I'm sitting in prep holding and I'm doing a block and I inject, and the patient starts to say, oh, I feel funny, oh, you're ringing in my ears, oh. So then they have a seizure and then they go into a coma. The question is, do you intubate the patient? One of the questions, there's a couple questions. Number one, how do you handle the airway? You guys all know how to do airway management by now, right? Of all the people in the world, I would say you're probably the top 0.1% of the people in the world that can do airway management, all right? That's fine. Whether you want to do an LMA, you want to intubate, you want to ventilate on an ambu bag, whatever you need to do, you guys will know how to figure it out by now. So the question is, do you need to put a tube in the patient? And the way I was taught, and I still to this day think it's a good idea, one of my preceptors taught me was, ask yourself, if this patient was having a general anesthetic, would you intubate them? And what he meant by that is this: if you get local anesthetic overdose, then they seize, then they go into a coma, that's stage 3, they don't have any airway protective reflexes. So if this was a general anesthetic and you had this exact situation patient, and you just put them to sleep, would you do them on a mask? If they're NPO and they're an easy airway, sure, why not? If they've had something to eat, full stomach, and they crush their fingers at work and they come in and you got to do a block on them to fix their fingers, and they've eaten, then if they overdose and they lose their reflexes, you better put a tube in them. So it isn't the overdose situation, it's the patient's history in the first place. And can you ventilate them or not? Are they easy airway? Is it someone that's hard? Someone that's hard, you might want to do an LMA or all the way to an endotracheal tube, whatever. It's a judgment call. But what you're faced is a situation where you have a patient in a coma with no reflexes. So handle it. That's it. You know what to do. If you think they're full stomach, put a tube in them. Protect their airway until they wake up and get their reflexes back. If they're empty stomach and they're easy to ventilate, just ventilate them with a mask until they come back and start breathing out on their own again. So just handle it that way. Just look at the situation, and you don't always have to intubate the patient or not. There's another controversy that goes on, and they talk a little bit about this in their recommendations. If a patient has a seizure, of course you can't do anything to a patient who's having a grand mal seizure on a stretcher in front of you. You can't intubate them, you can't ventilate them, you can't do anything. They're bouncing up and down, they have a seizure, right? It's pretty hard to do anything with that patient. So there's been a couple different schools of thought over the years. Nowadays, with Versed around, people will say, well, treat the seizure with Versed. The benzodiazepines are anticonvulsants, excellent anticonvulsants, so you give some Versed. You might have some in a syringe in your pocket, hopefully, whatever. Or you had some drawn up, so you're going to give the patient some, make them calm down for the block, and you have some extra. Go ahead and give the Versed and try to treat the seizure that way. Now, that's the good news, and it's probably worked pretty well. The downside is that once they get through the excitement of it, the seizure part, they're going to be very depressed. And you're adding to the depression by giving them Versed. So maybe that isn't the best thing to do. After you seize, you get what's called post-ictal depression. After the seizure, your brain shuts down a little bit and tries to go into depression to conserve energy. So, yes, treating the seizure is fine. Unless they stop seizing, you're not going to be able to put a blade in their mouth and intubate them, or put an LMA in, or even put a mask on their face and ventilate. So yes, give them Versed, but then you're going to suffer some depression after they stop seizing. The other side of the coin says this: just give them succinylcholine. Succinylcholine doesn't get in the brain. It doesn't stop the seizure, but it sure stops them from bouncing on the stretcher. They'll be laying real nice and still, relaxed. You can intubate them, you can ventilate them, you can do whatever you want to them. Sucks is pretty dramatic. 60 seconds later, you'll have control over that patient. You didn't stop the seizure, but so what? The seizure's going to stop on its own. What you did was to got control of the patient so that they can ventilate, make sure they don't get hypoxic, and they're going to be fine. So one school of thought says, even though it doesn't really treat the seizure, just paralyze them with sucks and handle them that way. I don't know what the right answer is. There's people that believe both. Either or. But I just want you to be aware of that controversy. In the little block kit, most of the people will have succinylcholine in there. So you can paralyze the patient if you have to get control of them in the middle of the seizure. Yes?
You just give Versed and then give her one, but it doesn't.
Yes, you could give Versed and then give her Mazicon, but you could do that, yes. But I think most people would be a little hesitant to use Romazicon because it can produce seizures in some patients. In other words, when you reverse the benzodiazepine, maybe they're back to seizures. Not likely, but maybe. So, yeah, question.
Is it possible that the patient can have some awareness during the seizure, and that when you give them the succinylcholine, they can have some awareness?
Yeah, good question. Will they be awake? No, never. They'll always be unconscious. Because once they seize, they always lose consciousness. So if you're afraid of, which your question implies is, if you're afraid to give sucks because they might be awake, don't worry about it. They'll always be unconscious. Yes.
At what point would you initiate like manipulative therapy, or like is there a certain, did it have to get a certain level of toxicity to do that, or like if you were able to turn them around, like would you use that every time?
Yeah, what we did is we saw the patient getting excited, they got restless, they felt funny. We hurried up and injected 2 milligrams of Versed, and the patient just kind of went to sleep. Just kept on breathing, but we had to hold the chin up a little bit. And about 15 minutes later, he woke up, looking around, oh, how you doing? And he was fine.
So you can just wait for it to wear off?
You
Like,
just
at
wait
what
for it to
point
wear
do you
off, yeah.
start doing that then? Like how bad does that have to be before you start that?
Well, if it's an electric procedure, you probably should wait until they regain their consciousness and make sure the patients are fine, take their vitals and so on. So usually it's going to take 15, 20 minutes for them to regain consciousness. And then you can either proceed with the case, which is what we did. Did the case and sent the patient home, and they didn't know any better. They just thought they dozed off. Or if the patient has a seizure and it's elective and they didn't do well, or you had to fight arrhythmia and all that, you probably should cancel the case and bring them back another time. So it's a judgment call. Both times the anticonvulsant was able to stop what we thought was an impending, last situation, and the patients did fine.
So you would use it more if there was like cardiac involvement, sort of?
Oh, if they have cardiac involvement, then you're going to give lipid.
That's when you give it.
Yeah, that's when you give the lipid. And I'm going to talk about it. I got it all in here. Yes.
This might be a stupid question, but if you're probably not going to have lipids sitting around, like in your crash cart, would you be able to potentially use propofol as like a bridge?
No, and that's a good question. You can't use propofol because even though it's a lipid vehicle, propofol, the drug itself is so depressing that it counteracts any benefit of the lipid. So, in fact, the regional society says right in their guidelines, do not use propofol as a substitute for lipid. And you have to have the lipid with you in a vial or in a preparation in the little kit so you can give it right away. All right, so let's go to page 93. With all that background, let's take a look at some of the American Society of Regional Anesthesia guidelines. And these are the recommendations for preventing LAST. Okay, bullet number 1. There's no single measure that can prevent LAST in clinical practice. The use of the lowest dose possible, volume, concentration, is the best idea. Use incremental injection. Give 3 to 5 mLs. Wait a minute or two. Give another 3 or 5. In other words, don't just blast in as fast as you can. All 40 mLs of the local anesthetic. Give it in small increments. Keep an eye on the patient. See if they start to show confusion. Any clinical signs, blood pressure, heart rate, whatever. If they get real tachycardic and you got epinephrine in there, you might be injecting a vessel. That's why they're getting sudden tachycardia. So just take your time and have a little finesse. When using a fixed needle approach, no matter how you're doing it, time between injections should encompass one circulation time around 30 to 45 seconds. So they're saying give 5 mLs, wait 30 seconds, give another 5 mLs. So you give the drug a little bit of time to see if it's going in a vessel. This ideal may be balanced against the risk of needle movement between injections. Circulation time may be increased with lower extremity. So if you're doing an ankle block or whatever, you got to wait a little bit longer for it to get all the way up to the heart and circulate around. The use of larger dosing increments would dictate the need for longer intervals to reduce when you're doing stacked injections. So if you're giving more, then wait a little bit longer for it to work. Incremental injection may be less important with ultrasounds because you're actually watching the solution inject into the tissue. And the needle movement is often used in these techniques. So in other words, be careful where you put your needle. Aspirate on the needle so you can see the blood returning into your syringe. You can realize you're not in the right place and take it out and start over. Wait several 30, 45 seconds between injections. Give it slowly and be careful. Next bullet. Aspirate the needle and pour a catheter before each injection, recognizing there's about a 2% false negative rate. In other words, aspiration doesn't guarantee you're not in the vessel, especially with an epidural catheter because it's so long and skinny that you can aspirate on it, and sometimes you don't get blood to come back. When injecting potentially toxic doses of local anesthetic, use an intravascular marker. In other words, put epi in there. Because if you see them get all of a sudden tachycardic, that's a good sign you're probably in a vessel and you just injected epinephrine IV into somebody. Although epi is an imperfect marker and its use is open to judgment, its benefits outweigh its risks. Intravascular injection of epi 10 to 15 mics in adults produces a greater than 10 beat heart rate increase and a greater than 15 milligrams of mercury blood pressure increase. IV injection of epi in children produces an even more increase in blood pressure. Subtoxic doses of local anesthetic can produce subjective symptoms of mild toxicity, for example, auditory changes, ringing in the ears, excitation, metallic taste, etc. And fentanyl 100 mics produces sedation if injected IV. Ultrasound guidance may reduce the frequency of intravascular injection, but actual reduction of LAST remains unproven in humans. Individual reports describe LAST despite the use of ultrasound. The overall effectiveness of ultrasound guidance in reducing the frequency of LAST remains to be determined. I think there's been a lot of studies now that shows it probably does decrease the incidence of toxicity because you can see where the needle is, you can see the injection going in, and that's always a good thing. Is it going to make it never happen again? I doubt that. All right, next page. 94. Recommendations for diagnosing. How do you know you're about to have an overdose situation? All right. Classic descriptions of LAST depict a progression of subjective symptoms of CNS excitement. agitation, auditory changes, metallic taste in the mouth, abrupt onset of psychiatric symptoms, etc., followed by seizures and then CNS depression. Then followed by cardiac depression, etc. You can also have simultaneous presentation of both the CNS and cardiac effects. Cardiac toxicity without prodromal signs and symptoms of CNS toxicity can also occur. So you can have all three different types. The timing of last presentation is variable. Immediate, less than 60-second presentation suggests an intravascular injection with direct access to the brain. Presentation that is delayed 1 to 5 minutes suggests an intermittent or partial IV injection, and delayed greater than 15 minutes after injection. Patient received potentially toxic dose of local anesthetic should be monitored for at least 30 minutes after injection. When you inject a large amount of local into someone, keep an eye on it for at least 30 minutes. Which most likely you're going to do because you're going to go do a case on them, right? That's not too tough to do. Case reports associated with LAS and underlying cardiac, neuro, pulmonary, renal, hepatic, or metabolic disease. Heightened vigilance is warranted in these patients. So if you get sick ASA 3 and 4 patients, be even more careful. You could have wrote that one, right? And lastly, the overall variability of the signs and symptoms, timing, etc., associated with different disease means you should have a low threshold for diagnosing LAS in patients. So if you even suspect it, you're probably right, and go ahead and start treating it. That's what they're saying. Now, when you do a block on somebody in the pre-op holding or whatever, even in the room, and you're trying to give them a little sedation so they're more comfortable getting injected with a needle, you don't want to over-sedate them because you want to be able to have them talking to you. That was very vital in the 2 that I had because I was able to keep talking to the patient. Hey, did you see the Tiger game last night? Oh man, did you see that home run? Oh, who came with you this morning? Oh, did you ever have surgery before? What about that weather? It doesn't matter. Talk to them about anything. But keep the patient talking and responding. Because if they're going to stop talking and start staring off into space all of a sudden, that's going to be a sign that, oh, something might be happening. Or if they get confused or restless and so on. So in other words, sedate them. Yes, make the patient comfortable, of course. But don't over-sedate them so they don't have any idea of how to respond to you. So you can carry on a conversation with them as you're doing the block and injecting the solution. See what I mean? All right, recommendations for treatment of LAS. I'm on the bottom of page 94. If the signs and symptoms occur, prompt and effective airway management is crucial to preventing hypoxia and acidosis, which are known to potentiate LAS. Remember, if you get the patient gets acidotic, then the local anesthetic is going to ionize in the brain, and it's going to be even harder to get rid of that toxicity because it's going to be trapped in the brain. If seizures occur, they should be rapidly halted with benzodiazepines. If benzodiazepines are not readily available, a small dose of propofol is acceptable. Future data may support the early use of lipid emulsion for treating seizures. Although propofol can stop seizures, large doses further depress cardiac function. It should be avoided when there are signs of cardiac compromise. If seizures persist despite benzodiazepines, small dose of SUX or similar non-polarizing blocker should be considered to minimize acidosis and hypoxia. It doesn't matter what you give. Stop the patient from moving, control the airway. As long as you do airway management and keep a patent airway and don't let them aspirate and whatever, all those bad things that can happen, the patient is going to be fine. Just ventilate. That's the important thing. Airway, breathing, circulation. If cardiac arrest occurs, we recommend standard advanced cardiac life support with the following modifications. So if the patient does arrest, then you're going to do CPR. Right? Next page, 95. If epi is used, a small initial dose, 10 to 100 micro boluses in adults are preferred. If you're going to give some epi to try to kick their heart and get them back again, use small doses. Don't use vasopressin, regardless of what the ACLS protocols. It seems to make it worse with local anesthetic. Avoid calcium blockers or beta blockers. If they have ventricular arrhythmias, amiodarone is preferred. Of course, treatment with lidocaine or another antiarrhythmic would not be the greatest idea. No demand. I hope that they don't even have to say that, right? And then you want to dose them with lipid emulsion. So lipid emulsion is just a lipid vehicle that we're familiar with propofol and other medications. But it seems to, if you give it IV, sequester the local anesthetic into the lipid and can bind it there in the lipid, then you can eliminate it safely. So one of the ways, they've discovered this with bupivacaine in the laboratory of animals, was one of the ways they could reverse bupivacaine toxicity, the only way, was to give this lipid emulsion and provide that as a binding platform for the bupivacaine, so it binds to that rather than the body, and then you can pee it out. So the dosing, and I got a little table on the bottom there for the dosing. Initially, IV bolus dose of 1.5 mLs per kilo of 20% lipid emulsion. I'm reading off the table on the bottom of page 95. Continuing infusion of 1/4 ml per kilo per minute for at least 10 minutes after the return of cardiac function. If cardiovascular instability continues, you can repeat, and up to 10 mLs per kilo over 30 minutes is recommended as the upper safe limit. Well, pretty straightforward, just give them IV lipid emulsion and it'll reverse. Now back up top again, propofol is not a substitute for lipid emulsion. Then finally the last bullet, failure to respond to lipid emulsion and vasopressin therapy should prompt putting the patient on cardiopulmonary bypass. Because there can be considerable lag in beginning bypass, it's reasonable to notify the closest facility capable of doing it when cardiac compromise is first identified. What happened was, in the smaller community hospitals where they don't have cardiac service, they can't put them on a bypass machine forever, then they had to transport them while they're beating on their chest over to another hospital and then get them on bypass. So you can imagine what a fiasco that would be. So that's pretty much desperate. Okay, so let's summarize it all. And we'll quit for the day. The next page, 96, here's a small summary of everything we just went through. I'm going to say it all again. Important stuff. How do you treat local anesthetic overdose? You want to be a CRNA, you got to know this. Here we go. Page 96. For patients experiencing signs and symptoms of LAST, this is from the Regional Anesthesia Society. First of all, get help. Get as many people in the room as you can get, because you're going to need extra hands. The initial focus should be airway management, ventilating with 100% oxygen, seizure suppression with either benzodiazepines or whatever, and then basic and advanced cardiac life support. Infuse the lipid emulsion, repeat it if necessary, continue infusions and give them some epi for blood pressure, etc. Avoid vasopressin, calcium, beta blockers, or any kind of local anesthetic. If you have to go to another facility for CPR bypass, that's possible. And then if you do use lipid emulsion, there's a national website called lipidrescue.org, and they would like you to go on there and describe the case. Because they're trying to get a compendium of various cases that did occur and how you treated it and how it worked and so on and so forth. So this is a national resource for all of us. Next, be prepared. We cannot strongly advise those using local anesthetics in doses sufficient to produce toxicity. Establish a plan for managing the complication. Make a local anesthetic toxicity kit and post instructions for its use. Have some morning conference at your OR to talk about a local anesthetic toxicity so everybody's on the same page. They know where you keep the little box and they know who to call and what phone number to ring. get a plan, make a plan. Risk reduction, use the lowest dose possible. Blood levels are influenced by the size of injection and the dose, so give incremental injections in the lowest dose possible. Considering using pharmacologic markers like epi, we talked about that. The next page, aspirate the syringe prior to each injection, looking for blood, inject incrementally, and observe for signs and symptoms. As far as detection goes, be vigilant, use standard ASA monitors, put a pulse ox on the patient, stick them on an EKG, and blood pressure cuff. Monitor the patient during and after completing injection and up to 30 minutes later. Consider last in any patient with altered mental status, neural symptoms, or cardiac instability following the block. CNS signs include, we talked about them, cardiac signs include, initially the patient may be hyperdynamic and then progress to cardiac arrest. Sedative hypnotic drugs reduce seizure risk, but even light sedation may abolish the patient's ability to recognize or report symptoms of rising local anesthetic concentrations. And finally, the timing of treatment. The timing of lipid infusion is controversial. There's some argument about when you should go to the lipid infusion. It's like DEFCON 10 or something. When you decide to give lipid infusion, then you're going to go all the way in. Some people think you should do it right away. First thing, many even suspect. Other people say, well, try some Versed first, try some salts, see if you can stop it that way, etc. So there's some controversy as to the proper timing. The most conservative approach, back to the bullet, waiting until after ACLS has proven unsuccessful is unreasonable because early treatment can prevent the cardiac collapse. Infusing lipid at the earliest sign can result in unnecessary treatment as only a fraction of the patients progress to such seizures and all the rest of it. Some it's more mild, it's just blood level goes down, it goes away. So the most reasonable approach is to implement lipid therapy on the basis of clinical severity and how fast the patient seized. There's laboratory evidence that epi can impair resuscitation from last and reduce the efficacy of lipid rescue. Recommended avoiding high doses and use smaller doses such as 1 mic per kilo. Propofol should not be used. Propofol is a cardiac depressant with lipid content too low to provide benefit. It's discouraged when there's a risk of progression to cardiac collapse. If they do have an overdose, prolonged monitoring is recommended after any signs of cardiac toxicity to make sure that the patient's going to recover. That's it. Okay, any questions? All right, see you next week.